Good morning, everyone. We're going to talk about Section 10 today, musculoskeletal problems. This section has several chapters that has a lot of information, and if you look at the PowerPoint that is in Blackboard, there are fewer slides in this, and I will post this PowerPoint deck into Blackboard. I have put some extra slides in, and I've put some supplemental videos in that will help you learn how to do or be able to visualize different techniques that you might do in musculoskeletal problems and the assessment that you would use for those. So we can't cover everything in the chapter by video, so be sure and read the chapter, and we're going to try to hit the highlights here in this video. So section 10 starts on page 789. And if you spent any time in the clinical setting, you have identified that one of the most common reasons for visits in primary care are musculoskeletal issues. Most acute musculoskeletal complaints are self-limiting, except there are some conditions that, if left untreated, can lead to joint instability and higher degrees of injury in the future if recovery is not complete. So we're going to try to make you feel more comfortable when you are assessing someone that presents with a musculoskeletal issue. Much of the diagnosis is dependent on the patient's reporting of symptoms, so you want to be sure and get an accurate patient history and be aware of the anatomy and physiology of the area that the person is having the issue with. These are all very needed to make an accurate diagnosis. There are several questions when you are first thinking through working on your differential diagnosis that you must consider. Is this an acute or a chronic condition? Is it articular or non-articular? Does the condition appear to be inflammatory or non-inflammatory? And is it localized or systemic? And we're going to go through these. With musculoskeletal issues, it's important to know the origin of the injury, and so that is typically articular versus non-articular. And articular structures include the synovial fluid, the cartilage, the ligaments, the joint capsule, the juxtaarticular bone. And disorders of these structures can be characterized by a deep or diffuse pain and limited range of motion when going through active and passive motion. There can be swelling, effusions, or bony enlargement. You can have crepitation and instability and the locking of the joint. Non-articular structures are more your supportive ligaments, tendons, the bursa muscle, fascia, your bones, your nerves, and your overlaying skin. These disorders are painful with active range of motion, but not necessarily with passive range of motion. You can have focal tenderness in the area. Crepitus and instability of the joint are not often associated with non-articular injuries. Inflammatory disorders may be infectious or idiopathic. And the four cardinal signs of concerns for infection would include inflammation, redness, warmth, pain, and swelling. Some systemic symptoms. You could have weight loss, stiffness, fever, fatigue, changes in labs that indicate inflammation, such as an elevated SED rate or elevated CRP. You could have anemia of chronic disease and elevated platelet counts. Non-inflammatory disorders tend to be related more to trauma. In your clinical history, you're wanting to assess for age, sex, race, family history, what their occupational history is, medications that they take, activities. You're wanting to see more of a timeline of how things have developed, and this may offer clues to the type of injury. On page 790 in table 52.1, there are musculoskeletal emergencies, and it talks about how the patient may present and what their H&P may be, and then what the musculoskeletal emergency might be and what to look for. There's also a great list of questions that you would want to ask the patient to help focus in on the musculoskeletal problem. And so those are found on page 791, and I encourage you to review those and try to incorporate these into your assessment for a musculoskeletal issue. On page 792, there's the advanced assessment of what is included in the musculoskeletal disorders, and be sure and look at that. We're not going to go through that, but it includes different general tests that you would need to do to try to further get information on what type of issue you are having. On your physical exam, be sure and compare sides for symmetry. You may have to have the patient undressed if needed to be able to check, hips, upper thighs. You want to be sure to have the patient perform all range of motion without assistance. And then we talked about any special maneuvers that are related to the physical exam, so you can learn more about the issue, and we're going to talk more about those through this video and have videos for you to watch. There are minimal tests that are used with true orthopedic issues. These tests can often be misleading and produce a false positive or false negative results. There are a few that may be considered, and we mentioned a few of those previously, but you may, depending on the circumstance, decide to get a CBC to get more information regarding anemia. We talked about inflammatory markers, SED rate, and a CRP. You might consider getting a rheumatoid factor or an ANA. You might check for Lyme antibodies. Check a uric acid if you were concerned for gout. Imaging may be used when your exam cannot localize what part of the body may be causing the symptoms, or if there's severe significant trauma, or if there's loss of joint function, if pain continues despite conservative treatments, if there's concerns for a fracture or bone infection, or if there's concerns for malignancy. As you know, we often start with plain films, but these may not show significant test for a patient that presents with acute or new symptoms such as back pain or an injury to soft tissue. They may confirm, though, like the diagnosis of osteoarthritis. Other tests that may be used could be ultrasounds for detection of soft tissue abnormalities, a CT that's going to assess more skeletal findings and be able to visualize the axial plane. They're helpful in diagnosing low back problems, herniated disc, spinal stenosis, any spinal trauma. MRIs are useful in soft tissue injuries, and bone scans can be helpful in diagnosing osteomyelitis, stress fractures, or if there's concern for bony mets related to a cancer. And then EMG or nerve conduction test may be used if there's concerns for neurological abnormalities or that paresthesias, the numbness, tingling that you may see with like carpal tunnel or a herniated disc. So here is a list of some of the differential diagnoses that could be brought into play with some of the things we've talked about over the last several slides. Sorry for the interruption. Not for sure if we went over this slide, but this is a list of some differential diagnoses based on several of the things that we have talked about on the previous slides. So in the book on page 794 and 795, we're talking about acute musculoskeletal injuries, and it's important to determine if this is an acute or a chronic issue. Acute injuries are going to be more damage to muscles, tendons, ligaments, nerves, and bursa, and are usually less than 6 weeks. You can have spasms, which are more persistent, painful, and reversible contracture of the muscle. You can have a strain, which can be excessive tension placed on the muscle that results in stiffness and decreased function. And then a sprain, which is a stretching or tearing of the ligament that occurs when the joint is forced beyond its normal boundaries. On 795, there's a good algorithm for a musculoskeletal complaint and your diagnostic reasoning of how you might work your way through. So I encourage you to review that. Most acute injuries or pains do not require any emergent treatment. We likely have heard of the acronym RICE. There is a new acronym on the market that is called PRICE, which is Protect and Rest. The affected part, apply ice for 48 hours, compress with like an ACE wrap, and to elevate. So be sure and speak with your patients about ways to help manage their injury. It's important to limit activity. Physical therapy may include heat or cold with the help of returning the patient to full function as soon as possible. Cold and ice are recommended for the first 48 hours to help with inflammation, and then heat is recommended to bring blood flow to the area to provide healing. Pain relief is important, and NSAIDs are the first line of pain medication. You always want to educate your patient on GI concerns with long-term use NSAIDs, and opioids are not indicated for acute muscle injuries and should be avoided. Next, let's talk about paresthesia. That's the sensation of numbness, prickling, or tingling in central or peripheral nerves. This paresthesia can result from anatomical or mechanical peripheral injury, such as entrapment or compression issues. They most likely happen at areas that are susceptible to damage due to an increased pressure or mechanical forces. Be sure to review the differential diagnoses that are in the book. And then next, we'll briefly talk about myofascial pain, which is a muscle pain that has trigger points within the muscle. A trigger point can cause local irritation when it's activated, and this pain can have a referred pain. Treatment for this type of pain includes identifying and eliminating any aggravating factors. You may use trigger point injections, dry needling, massage. Some research suggests that muscle relaxants can help in decreasing muscle spasticity and decrease pain. Be sure to note that these should be used sparingly, as there have been the potential for addiction with your patient with this medication class. Next, let's talk about neck pain, and that is discomfort or limited range of motion, and it's a very common complaint in practice. It can include numbness, tingling, and radiation, or localized pain. It can originate from musculoskeletal structures, including your muscles, ligaments, tendons, your cervical vertebrae, nerves, and the vasculature in the area. It can be referred to the neck from TMJ or concerns in the mediastinum. Most causes are structural and often are the result of trauma, degenerative changes, or muscle spasms. Physical exam, it begins with evaluation of range of motion. You're wanting to check flexion, extension, rotation, and side bending. You can perform a Sperling's maneuver to assess nerve root compression. This is a video that I did not include in this, so if you are interested in learning more about that, I encourage you to go out and search through YouTube. There is an advanced assessment for Sperling's maneuver found on page 798 if you want to review that. Some red flags to be concerned about with neck pain is if you have a patient that has fever, loss of function, redness, or any concerning systemic symptoms. I don't like how this power deck was laid out, and I tried to add some slides in from an old power deck, that PowerPoint deck, but the flow doesn't seem to be going as well as I'd like. So we are going to move forward, but we'll be back to talk about back pain. So some differential diagnoses for neck can include spasms, cervical radiculopathy, torculosis, myofascial pain, whiplash, spondylosis, strain, and you can have referred pain. When you're assessing, you want to make sure to see if there was any precipitating event. You want to assess for range of motion. You may be able to palpate muscle spasm. Pain may be described as numbness, tingling. It may radiate or it may be localized. It's important to know the age of the patient because you're wanting to assess for any degenerative arthritis. And then we know about these as systemic red flags. In the management of pain in the neck, be comfortable wanting to refer to an orthopedist or neurologist if you feel that there are emergent symptoms. Conservative treatment would include rest followed by gentle range of motion as tolerated. NSAIDs for inflammation if not contraindicated. As we mentioned earlier in another symptom, short-term muscle relaxants if no contraindication, and ice or heat and physical therapy may be needed. So this is one of the first videos that we have. I'm not going to play the whole thing, but I want you are able to double click on it, and then I just want to show you how all of them should work, and then you're able to hit the start button. And this is a particular
What's up, guys?
one
Dr. John
for the
Russin
Apley
here.
Scratch test to assess more neck and shoulder movement. So there are several of these that are worked in throughout this slide deck, and I want you to be sure and review those. This is another one, and we won't stop to look at that. The next thing that we're going to talk about in the book is back pain. So I've gone back up to one of the previous slides, and I apologize again for jumping around. But let's talk about back pain. And approximately 85% of the adult population can experience low back pain at some point in their lives. Common causes can include lumbar strain and sprains, could be nerve impingement, compression, radiculopathy. It could be related to fractures. The most common cause of lower back pain is strain and sprains, and this occurs when the muscle or the ligaments in the lower back are stretched, causing some microscopic tears. And sprains are caused by the overstretching of or tearing of the ligaments. These lumbar strains and sprains usually occur from overuse, improper use, or trauma to the muscles and connective tissue of the lower back. There can also be fractures, which can be associated with an acute onset of pain that can radiate around the body. There can also be malignancies or localized infections that could be contributing to the back pain. Your initial exam is important because you're looking for inspection of the spine, the lower extremities, and their gait, how well they walk. You want to be able to watch them walk towards you and walk away from you. You want to assess the back, spine, and legs for asymmetry, if there's any atrophy, lesions, trauma. You want to assess if there's any differences in leg length. You want to be able to assess the knees and the hips, standing, sitting with the knees bent, and lying in a prone position. You also want to be able to perform a neurological exam to see if there's any deficits produced by disc disease, or if there's any larger complications such as compression of the nerves causing cauda equina due to spinal tumors. Vertebral disc herniation that leads to radiculopathy of the lumbar spine nerves typically happens in L4 to L5 and L5 to S1. In the book, there is a long list of potential causes of lower back pain, so I encourage you to read through those. Some are musculoskeletal related, some are infections, some are organ inflammation. So there's a wide variety of things that can contribute to lower back pain. So be sure and review that on page 800 and 801. Next, let's talk about shoulder pain. And this is pain or dysfunction that can occur or in the shoulder girdle and are common in musculoskeletal complaints. It can happen to a variety of ages and different activity levels. This pain can be referred from a variety of regions such as the neck, the chest, or the diaphragmatic region, but it is most commonly caused by a local process. Just as a refresher, the shoulder joint includes three large bones: the clavicle, the scapula, and the humerus, and four joints. The sternoclavicular, the acromioclavicular, the glenohumeral, and the thoracoscapular. Common conditions affecting the shoulder can be caused by acute injuries um, and usually are less than 2 weeks of duration, and they're common in younger patients. And these can include fractures and dislocations, tendon rupture, and degenerative and inflammatory conditions. When you're assessing this patient, you should ask about any precipitating injury, when the pain began, where is the pain, and any factors that aggravated or alleviated. It's also important to see if there is a relationship to the pain for the time of the day, whether it's during active or passive motion, or the position that the body is in. This is also important to be able to assess the patient's occupation, activities, medical history, and social factors. Patients that typically have acute symptoms usually have an injury that's related to a fracture, dislocation, or a rotator cuff injury. Instability of the joint is common in younger adults and can be classified by the frequency of the symptoms as well as the direction and the degree of the instability. So be sure and review that on page 801 in the second column. You're wanting to assess for the frequency, the degree, and the location of the instability. Your physical exam of the shoulder will be with a visualization first. You're looking for swelling, color, swelling, edema, and symmetry. You're going to do a physical palpation to assess for any tender areas, crepitation, if there's a deformity, if there's any temperature changes. You want to look at the shoulder both anterior and posteriorly, and you want to look at the scapula to note if there's any winging going on. You want to check for active and passive range of motion. You'll want to check for internal and external flexion of the elbow, which is going to tell more about the movement of the shoulder. You're wanting to know also to abduct and adduct the shoulder, and then also you'll want to perform the Apley test, and that was one of the first videos that we had listed, I believe. So be sure and review that to get more information on best ways to assess movement of the shoulder. On page 802, there is a differential diagnosis chart that I'd like for you to review for shoulder pain. It breaks them down into musculoskeletal problems, trauma issues, neurovascular problems, and then if there is systemic disease and what the differential diagnosis might be. So be sure and review those. And let's talk next about elbow pain. It's a common complaint in adults that often is reported due to overuse. And the most common is the lateral epicondylitis of the humerus, and often this is referred to as tennis elbow. It got its name because, but it can happen to patients who do not play tennis. It's associated with a repeated extension of the wrist and pronation and supination of the forearm, particularly against resistance, which occurs with movements such as hammering, turning doorknobs, and opening jars. The most common complaint is that you have pain at the elbow that radiates into the forearm and a decrease in gripping. Treatment includes rest, ice, NSAIDs, and physical therapy if necessary. Corticosteroid injections and wrist splinting may be needed in some cases. Another less common, condition that's considered the golfer's elbow or the medial epicondylitis is a result of overuse or strain of the muscle groups from the media epicondyle, which is used in wrist flexion. And tenderness and pain is found and is exacerbated by the wrist flexion. And diagnosis is usually made by clinical exam, and treatment is the same as for lateral epicondylitis. Also, briefly, bursitis is often a cause of pain and swelling in the posterior part of the elbow, and this can occur with a forced extension of the elbow joint. Range of motion is usually normal, but there can be concerns for a septic bursitis, so you want to be sure and monitor for fever, redness, heat, and warmth of the site. We're going to finish off this video and we'll come back to finish off section 10 in the next video. Thank you.